great venue and just a wonderful time. Thank you very much.
Well, you're most welcome, John. Maybe I can just say welcome to everybody out there. We can get things started. And last night we had a really nice evening to recognize John Lloyd's tenure as program director. And it was very, very nice, except for the hideous wall plaque that he got from MND. But thanks again, John, for the great job you've done as program director. Amity Pry now is officially our residency program director, and Amity, great to have you at helm. And welcome everybody to our first grand rounds of the academic year. We've been talking about whether we were going to have in-person rounds or not, and the decision is that we'll stay virtual for the rest of 2022. We might go to a combined in-person and virtual in 2023, but we'll keep everyone posted. There's been suggestions that maybe we can rotate grand rounds at the different TAS and hospitals. We'll certainly keep everyone posted. Dr. Cindy Lamb is starting things off, and thank you very much, Cindy. And I'll turn things over to Dr. Rai to do the introduction and get things rolling. MND.
All right, thank you, Sherry, for the kind introduction, and thank you, John, for many, many years of service to our department. So it's my pleasure to launch this year's Grand Round series virtually once again. And the first presenter of the year is Dr. Cindy Lamb, who I've known for a very long time. We were medical students together at the University of Western Ontario. And she subsequently did her ophthalmology training here at UofT, followed by a neuro-ophthalmology fellowship also at UofT. And she now is on staff at UHN and practices out of the Kensington Vision and Research Center. And she's got two excellent residents with her today, Dr. Alan Zhao and Dr. Ryan Mason. So I'll turn it over to them to get the talk started.
Thank you very much. I hope everyone can see the screen. So welcome back from the summer. We hope it was a good one. We're very honored that the first grand rounds of the academic year is the neuro-ophthalmology topic. And today, I'm Cindy Lamb, and today we have two excellent superstar residents who are going to take you through some tough cases titled When Seeing Double Means Trouble. So our objectives today are to do a deep dive into cranial nerve 6 palsies, as well as an approach to multiple oculomotor palsies. We selected cranial nerve 6 palsies as the singular nerve palsy to talk about because it is the most common cranial nerve palsy that you'll come across in your clinic. So we'll start off with an easy case. This is a 71-year-old male who presents with a one-day history of binocular horizontal diplopia. It is not associated with any pain. He has vascular risk factors. He has a normal visual acuity on exam and a normal anterior segment and posterior segment exam. Here is his extraocular motility movements, and I apologize for the terrible videos. I think I'm notorious for taking bad videos, but we'll try our best here. So on exam here, you can see that there's full extraocular movements on left gaze. And then on right gaze here, you can see there's a -2 to -3 abduction deficit of the right eye. Up gaze is full and down gaze is full as well, but you'll note that he also has an esotropia. So on exam, he has a large esotropia that's worse on right gaze and better on left gaze, as well as a right abduction deficit. There are no other cranial nerves involved, and there's no other neurological deficits on exam. So we'd like to bring up our first audience poll here. So for this patient, what would you like to do next? So the options are to observe. Second option is to do a bit of blood work and check for thyroid and myasthenia antibodies. Third option is to do a CT scan of the orbits. And the fourth option is to do an MRI of the brain.
Thanks, Cindy. We'll give that a couple seconds to get some results in. So we've got a bit of a split here.
Okay, very good. So we'll go on. So in this case, I will just close the, oh, perfect. So in this case, given the patient's vascular risk factors and age, we chose to observe. So 3 months later, the diplopia has completely resolved. On exam, he has only a small esotropia still. That's worse on right gaze, better on left gaze. We did not do any other investigations. And at 6 months later, we followed him up and it had completely resolved in terms of the eye, and he was completely orthophoric in all gazes. So why did we not proceed with investigations in this case? Why did we defer them? So the reason is this is most commonly in a patient over the age of 50 who has vascular risk factors with an isolated cranial nerve 6 palsy. The most common etiology 50% of the time is a microangiopathic cranial nerve 6 palsy. And the majority of these completely resolve without any sequelae. And because it's a relatively benign condition, we usually can defer imaging as potentially it is not cost effective to image all patients with this condition. So that's the first case. And we will move on to Ellen's case.
Thanks. Can I share my slides?
Yes, I'll just stop. Okay.
Now, Cindy, as she's doing that, are there any sort of cases where you might be more concerned at the initial presentation?
Yes, so we'll go over that later in the slides as well. But if it's not an isolated unilateral cranial nerve 6 palsy, and if the patient is not over 50 and he does not have, they do not have vascular risk factors, then usually imaging is potentially indicated. So there's only a very specific subset of criteria where you can defer imaging.
Perfect, thank you.
Hi everyone, my name is Ellen. I'm a TGY4 in the program. So today I would like to present a case that I saw a couple months ago when I was doing my rotation at sick kids. So late in the afternoon, I was working at the Emerge clinic, got a page from the ER doctor. It was a relatively busy day. So the ER doctor said to me, hey Ellen, look, seems that I have another patient with ESO for you. So this time it's an 8-year-old, otherwise healthy boy. His left eye has turned in for months, so it looks very chronic. His vision is excellent. He doesn't have diplopia either. So would you like to see today or tomorrow? So as I was chatting with the ER doctor, I was thinking about the differential diagnosis for esotropia in kids. So first we must differentiate between pseudo-esotropia versus the true esotropia. And within the true ESO, there are incomitant forms and comitant forms. Under incomitant esotropia, there are 3 causes. First is neurogenic, including 6-nerve palsy, Duane syndrome, and Mobius syndrome. Mechanical etiologies include medial wall fracture or strabismus surgery, or sometimes due to high myopia. Myogenic etiology includes thyroid eye disease, myasthenia gravis, and in children, we must think of CFEOM as well. As for comitant esotropia, infantile flavor usually involve large angle and very low hyperopia. Accommodative esotropia can be further divided based on the ACA ratio. And the third form, acquired non-accommodative esotropia, involve several types of ESO, such as basic ESO, cyclic esotropia, and sensory ESO. So my job in the Emerge clinic that day was to rule out the dangerous causes. So what questions do you have to ask before making a triage decision? First, do you ask past medical history, any history of amblyopia or patching? How about the EOM? How about his vision? Does he wear glasses? Does he have any neurologic or constitutional symptoms, or all of the above?
Thank you, Ellen. So we'll give that a couple seconds to work. I will tell you that one of the challenges with this is you may not get all of this information at the time to appropriately triage, but there's certainly appropriate questions. So let's see what the audience thinks. There's an overwhelming response towards all of the above.
Yeah. So I asked the ER doctor about all these, and he said there's no history of amblyopia. He has normal vision wearing his myopic glasses. His left eye appears to have near normal EOM, only slightly reduced on lateral gaze compared to the right eye. What caught my eye was the fact that this boy was wearing myopic glasses and that there's a slight reduction on lateral gaze of the left eye. So I asked the patient to be sent to my clinic, and I met the patient and his mother told me the whole story. Apparently 2 months ago, the patient was playing on the playground, he fell, and then he had torticollis, kind of neck pain or neck turn, but neither of them can tell me which side was turning to. And the boy started to have the left eye turn in. For a few days, he complained of double vision. The mom was very worried and concerned. So she brought the boy to see chiropractors and PT after several appointments with like multiple neck and spine manipulations. And after all these appointments, the boy said, my neck problem's gone. I don't have double vision anymore. But the mom decided to bring the kid to ER because she noticed the left eye is turning more and more in. And throughout this interaction, the boy was unusually quiet. On my exam, he has normal vision, pupil, IOP, there's no ptosis, cycloplegic refraction show about -3, -3.5, both eyes. On EOM, there's no narrowing of the palpebral fissure, making Duane syndrome less likely. However, at primary gaze, you can appreciate very obvious ESO of the left eye. The same holds true for the up and down gaze. I asked him to look to the left, and he was not able to abduct the left eye at all, but he was able to look to the right and adduct the left eye. So I asked the boy again, do you really don't have double vision? And he looked at his mom and said no. So I asked the mother to go to the tim and grab a juice for the kid. As she left the room, I asked the boy once again, do you have double vision or not? And this time he said, yes, I've been seeing double all this time. On my orthoptic exam, once again, there's an obvious abduction deficit of the left eye, and the esotropia is very concomitant. Posterior segment exam show normal optic nerve. There's no papilloedema or pallor. So at this point, what would you like to do? Order a CT orbit, MRI brain, update his glasses, or patch his left eye?
It's a good trick you had there for the mother. Good distraction. I like it. So there seems to be an overwhelming response. So I'll share the results with you here. 3/4 of the audience picked MRI brain. 1/4 picked CT orbits.
Yeah. Great job. I ordered MRI. So can you see the problem? Seems that he has a golf ball in the brain. So the radiologist paged me back saying that, hey, don't let the patient leave the hospital. So apparently he has a giant bacillary artery aneurysm spanning from the vertebral bacillary junction all the way to the superior cerebellar artery. And there is a marked compression of the brainstem and fourth ventricle. Because of the aneurysm, the distal flow within the bacillary system is greatly reduced. There was also significant crowding of the neural structure at the foramen magnum. So urgent consult to ICU and neurosurgery was initiated. He was admitted under ICU, who mandated a low normal BP less than 100. And they specifically noted that this boy is at risk of aneurysmal rupture with limited therapeutic options and very high risk of death. Interventional radiology IR was consulted also, and they are present in the audience today. So they highly recommended coiling the aneurysm. So as you can see, the IR first performed a cerebral angiogram. They injected the dye from the vertebral arteries here, and the dye went into the aneurysm, causing there some turbulence flow. And thankfully, there wasn't any thrombus within the structure. So in order to coil the aneurysm, they must make sure that the circulation is patent. So they perform a balloon occlusion test. They deploy 2 balloons at the vertebral basilar junction. This is to make sure that during the procedure, a few minutes procedure, that the anterior circulation from the circle of Willis can perfuse the posterior fossa as well. And their tests demonstrate very good cross circulation, and there weren't any changes in neural monitoring during the occlusion. So the coiling was a go. They deployed the coils from the right vertebral artery, and you can see the wires within the aneurysm. 1 week after the coiling, the MRI showed a complete occlusion of the aneurysm. There wasn't any acute hemorrhage or infarct, and the circle of Willis, as you can see here, was completely patent as well. So I'd like to thank the staff, Dr. Tarani Mathusami and Dr. Farinas, for helping out in this case. And this case also allowed us to discuss the neuroanatomy of 6th nerve. So basically the 6th nerve nucleus is in the pons here, and the facial nerve fascicle wraps around the 6th nerve nucleus, forming the facial colliculus. Then the 6th nerve exits through the pons medullary junction here, more medial than the facial nerve. At this point, ICA is right next to the 6th nerve as well. Then the fascicle of 6 climbs up the clivus, arrive at the petrous part of the bone. So both the clivus and the petrous part of the temporal bone are the bony structures. It passes through a structure called the Doral's canal, which is formed by the Gruber's ligament on top and the petrous part of the temporal bone at the bottom. The 6th nerve exits the canal and travel up to the cavernous sinus. Within the cavernous sinus, the nerve passes by the internal carotid artery and sympathetic plexus. It exits through the superior orbital fissure, arrives at the orbit, and supplies the lateral rectus. Because the 6th nerve has the longest intracranial course, it can be easily affected by a change of ICP, either a sudden increase of ICP or lowering of ICP. So here are a few images showing where 6th nerve can be affected. It can be affected by any space-occupying lesion here, or a change in the ICP as it was traveling in the brain. Any bony abnormality or trauma to the bone here can be also affected by aneurysm of the ICA or ICA. Of course, any infiltration process, inflammatory things, or trauma to the superior orbital fissure can affect the 6th nerve as well. So as for 6th nerve palsy etiologies in adults, most frequently is due to microvascular ischemia, followed by trauma and other causes. Things like multiple sclerosis, cancer, and inflammations are relatively rare. However, in people above 50 years old, we must rule out the possibility of GCA as well. As for children, brain cancer is the #1 cause of 6th nerve palsy, followed by increase in ICP of any causes, trauma and congenital reason as well. In fact, aneurysmal compression that causes 6 is extremely rare in both children and adults. So because esotropia is such a common presentation in children, we must rule out the dangerous ones from the common ones. And here are some red flags that we can look for. First is incompetency, restriction in EOM, or diplopia, nystagmus, having head turn, being progressive, not being hyperopic, or the lack of glow retraction, which may suggest a Duane syndrome. Any of these red flags should trigger a referral or neuroimaging. Sixth nerve palsy can be either a localizing sign or not localizing. When 6 is combined with a Horner syndrome, we should think cavernous sinus. When there's problem with the 6 and 7, they can be localized to the brainstem, as where 7 was wrapping around the 6. Then 6 can also be not localizing because, as we discussed before, it can be affected by a change in ICP. But if you see 6 with a papilloedema, then most likely there's an increase in ICP. So with that, I will, Dr. Lam will discuss the next case.
Ellen, thank you for that. Actually, before we get to Dr. Lam, we also have Dr. Carmen Farinas, who's involved in the case on our panel. And I don't know if she's got any further input on this case to share with us.
Hi, thank you. So yeah, my name is Carmen and I am a diagnostic and interventional neuroradiologist now at the Sick Kids. So basically about this case, what I want to say is that that was a fantastic pickup done by Ellen and all her staff. It was very uncommon presentation, very uncommon to have an aneurysm that size in an 8-year-old. So basically, what I really want to say is that the kid is doing very well. The aneurysm was, as I said, like very big. So actually we had to use coils that actually are used for abdominal aneurysms, so for very, very big aneurysms. And to our knowledge, this is the first case that those coils were used intracranially. Right now, and I know because I saw him yesterday, bilateral vertebral arteries are patent, bilateral PCAs and basilar arteries are patent, which is a fantastic result. So again, Ellen, thank you, and all of you, all the staff. You did a fantastic job. He's doing great. Family is extremely grateful.
That's fantastic.
I wonder if I can ask a quick question. Thank you for the case. Dr. Farinas, it looks like those coils would still allow some blood flow around the coils. Are they so dense as to block blood flow completely, or how do they actually work in stopping blood flow to the aneurysm?
Thank you for the question. So actually, this picture that we are showing, that we are seeing now on the left, is the beginning of the coiling. So actually, the aneurysm right now is much more dense, coiled. However, those coils, the way it works is that they have like a little bit of inflammatory reaction. So in addition to that, when you stop that such amount of high flow into an aneurysm, just because of this new flow and the turbulence that you create, putting something from outside the body to an aneurysm, the aneurysm starts clotting itself, and that's how they work. So actually now the aneurysm is completely clotting, and he's been having like several MRIs and CTs since the first one post-coiling, and actually you can see that in each of them, every time the clotting is bigger until now that is completely clotted.
Thank you. And are they at higher risk for embolic disease after this? Do they have to be anticoagulated, or do they?
Very good question, this one. So actually, yeah. So he's on aspirin, baby aspirin 81, and because the amount of the aneurysm, like the size of the aneurysm, because it's very big, right? And he has like a lot of clot inside. So normally in another patient with a smaller aneurysm, we would have stopped the aspirin by now, and actually in him we are going to keep him on aspirin still 1 year more probably. This was recommended by the thrombosis team here at the Sick Kids. So yeah, he has a pretty high risk of developing like some kind of embolia or anything like that, but hopefully it does not happen.
A follow-up question. You've got all that coil in there, and then it thromboses, but you still have the big physical structure, presumably producing some sort of mass effect. So does it eventually shrink a little bit, or does it remain just as large and therefore still push on the structures?
Yeah, so actually we hope for it to shrink, but the thing is that until now it did not shrink at all. So Ellen was talking and commenting about that 2 months before he fell, but probably this aneurysm was there from a long time ago, even like years. So now his cerebral structures, like they get used to have this aneurysm, right? So he's functioning completely normal. So normally those aneurysms, you always hope for them to shrink, but not always happen. In his case, I would say that probably he had this for a long time, and for that reason, he's been like developing and getting used to this new condition, and then one day something happened, and then he developed the nerve palsy. It's very difficult to guess. So if it does not shrink, I'm sure, like I completely believe that he's gonna be asymptomatic.
That's a fascinating case. Sorry, someone, I think Cindy was saying something.
I think Ellen can comment on this more, but I think clinically in follow-up, the patient still had a persistent sixth nerve palsy.
Yeah, so the thing is, remember, he doesn't have papilloedema. And when I discuss this case with radiology, they say as if the brain has evolved in such a way that it was hugging the aneurysm. So most likely he grew up with this aneurysm for years. And that's why the brain learned to adapt to this structure. And most likely he doesn't have high ICP either, because the optic nerve were completely normal. Another thing is, yes, he had persistent sixth nerve palsy on the left side. So I think ophthalmology is still following him, and just wait 6 months before it stabilizes to have strabismus surgery.
You do want to be careful following these patients to make sure that they don't develop amblyopia as well.
Thank you. That's a fascinating case. I guess another question I have is, I'm sure he was thoroughly investigated, sick kids. Was he found having underlying connective tissue or other disorder?
So he does not have. He's been investigated, and actually we did like huge amount of diagnostic tests. We did not find anything yet. The only thing that we have missing is that we are sending him and family to do genetic testing. Not sure we are gonna find anything in addition, and I think Ellen mentioned it. He does not have any family history of aneurysms or any other connective tissue disorders.
Okay, well, thanks for sharing that. That's a very fascinating case. There's one question from the audience, maybe for one of our ophthalmologists here. How do you handle the diplopia until the strabismus surgery can be done?
So basically, right now he is not, so he's patching. I think he was patching for a few hours, and then based on the last note, he was not patching. I don't know why, but then the vision right now is 20/25. Another thing is that he actually developed a little bit of the right sixth nerve palsy as well. So because the coiling is a little bit inflammatory, so I think the right six is affected somewhat. So right now, actually, he looks more straight than before. But of course, either eye can move left or right much. But at primary, he looks pretty good. So I think that was the reason why he's not patching at this point.
Got it. And are we using any prisms for him? Like prismatic correction in his glasses at all?
Yeah,
or is he...
Based on the last note, I didn't see any prism prescribed.
Okay, thank you. Yes, exactly. And Dr. Kraft just said the same thing. Thank you. Perfect. So there's no further question in the chat, so we can go on to Ryan's case, but thank you for sharing that. Very cool case, Ellen.
I think I have a case next, and then Ryan will follow. So thank you very much as I pull up my slides for that incredible case, Dr. Farinas and Dr. Zhou. I believe they will be publishing this case, and it will be coming to a journal in the near future. So I'm just going to share my screen here. Okay, so moving on to the next case. What if the patient is a little bit older? So here we have a 32-year-old female. It is during the height of the pandemic and she's only been staying at home. She's sent in by her optometrist relative for concerns of diplopia. And her history is that 3 months prior, she developed headaches with light sensitivity that lasted for about a week and then went away. However, a month later, she developed a very persistent headache and had become very photophobic and had begun to spend all her time in dark rooms. A week ago, she started to notice that her eye was pulling inwards and she developed constant binocular horizontal diplopia. She had called her family doctor for a virtual consult and was told that the diplopia was probably due to migraines and started on some migraine medications. On exam, her vision is normal in both eyes. The pupils are equal and reactive, and there is no ptosis. The anterior segment exam is normal. And here is a video. Again, I apologize for the poor quality. However, in primary gaze, you can see there's maybe a little suggestion of a bit of esotropia with interning of the, I would say the right eye. It's more obvious in clinic, but here's the video. I'll just pause it here. It's pretty subtle on the video, but on left gaze here, you can see maybe that there's a little bit of an abduction deficit. The eye does not abduct all the way here, whereas there's full adduction here. There's a bit of asymmetry there. And a little bit more this way, you can see there's more of the sclera showing there. So a slight abduction deficit of the left eye. And then here, and then on right gaze, here you can see more of an obvious abduction deficit of the right eye. In summary, she has bilateral abduction deficits, worse on the right compared to the left, consistent with bilateral cranial nerve 6 palsy. So here are her measurements. So she has a large angle esotropia that's worse on right gaze compared to the left gaze. You'll notice here that there's slightly less incomitance than you would expect with a unilateral 6 nerve palsy because there are bilateral abduction deficits. Interestingly, she also had a left hypertropia that was worse on left gaze and left head tilt. And this is not in keeping with a 3-step test for a cranial nerve 4 palsy. So what is going on here? A patient has an incomitant bilateral abduction deficits concerning for bilateral cranial nerve 6 palsies. She also has an incomitant left hypertropia, not in keeping with a 3-step test. So with all of these findings, there would be a concern potentially for multiple ocular motor nerve palsies. So Dr. Ryan Mason will go into more of this in detail as well. But in terms of an approach to this, just briefly, if you start anteriorly, and you try to figure out where the lesion is, you could look at potentially the extraocular muscles. So something like thyroid eye disease that affects multiple ocular muscles, or something at the neuromuscular junction, such as myasthenia gravis, that can affect multiple extraocular muscles. And then going more posteriorly at the orbit or at the orbital apex, where the cranial nerves 3, 4, and 6 travel very closely together, is another potential area of concern. Posterior to that is the cavernous sinus, where the cranial nerves traverse very closely together. And then posterior to that, the fascicles travel to become the nuclei at the level of the brain stem. And then there are also potentially supranuclear causes of vertical deviation, such as skew deviation, which is usually due to a lesion of the supranuclear vestibular inputs, as described by Dr. Agnes Wong. So here, I would like to ask the audience a question. What would you like to do next? First option is, would you like to observe? Second option, would you like to do a more thorough exam to look for other deficits? Would you like to send to orthoptics for prisms and a neurologist? Or would you like to send this patient for an urgent CT scan?
So we'll give that a couple more seconds to run there. But once again, Cindy, you seem to have a bit of a split. So about actually 64% now want a thorough exam, while 36% was sent to the emerge for a CT scan.
Perfect. So just as a comment, I think usually for us in terms of if there's anything in the brain or intracranial causes, we would usually prefer an MRI scan. However, there are instances where a CT scan is more appropriate. So being kind of the nerdy neuro-ophthalmologist that we are, we would like to do a more thorough exam to kind of help localize where this problem might potentially be. So here's the neurological exam. It is essentially otherwise normal. There's no motor or sensory deficits. The rest of the cranial nerves are normal and there is no ataxia. So here's the patient's fundus exam. And you can see here that there's marked bilateral optic nerve swelling. Please remember, as before, that the patient had normal visual acuity. So optic nerve swelling with preserved visual acuity usually suggests potentially bilateral papilledema. Here's the patient's OCT measurements. As you can see, there's marked elevation of the optic nerves on OCT. And the patient did not have any vision changes, but we did do peripheral vision testing. And she also has a left homonymous hemianopsia, which was asymptomatic for her. So trying to put this all together, where is the lesion potentially? The patient has papilledema. She has bilateral cranial nerve 6 palsies, as well as a left homonymous hemianopsia. So trying to put all this together, I had concerns for a very large, potentially compressive mass involving the right visual pathway, causing increased intracranial pressure. And as Ellen mentioned, increased intracranial pressure can also exert traction on the cranial nerve 6, which has the longest intracranial course and cause bilateral cranial nerve 6 palsies. So now we send the patient to the ER for imaging. In the ER, it's quicker to obtain a CT scan. So this patient had a CT scan done. And here it shows a large heterogeneous poorly defined mass in the right cerebral hemisphere. It involves the right temporal lobe as well as the right parietal lobe. There is herniation of the brain contents, and there's a 9 millimeter midline shift with compression of the right ventricle as well as dilation of the right ventricle. So clearly a cause for increased intracranial pressure. Here's the MRI that was urgently then ordered. And there's a very large infiltrative mass, again, involving the right temporal, frontal, and parietal lobes, as well as extension into the right lateral ventricle and the right occipital horn. So neurosurgery is consulted urgently. And the patient is admitted, and as much of the lesion is resected as possible. And the pathology for her comes back as a grade 2 glioma. So just a little bit about gliomas, as it is the most common primary brain tumor that affects adults. It is actually glioma is actually a common term for any tumor arising from the glial cells, which are the support cells of the brain. So they can come from the astrocyte line and form astrocytomas, the oligodendrocytes and form oligodendrogliomas, or ependymocytes and form ependymomas. So there's 4 gradings for gliomas. Grade 1 usually occurs in children, and it's slow growing, luckily, and is usually curable by resection unless it involves the brainstem. Grades 2 to 4 usually affect adults. And unfortunately, as you've seen on the MRI, because they are very diffusely infiltrating, they are not curable completely, usually by surgery. And the patient will usually require chemo or radiation to help. So this patient had a grade 2 glioma, which is luckily a low grade diffusely infiltrating glioma. It usually occurs in young adults, and the median survival is usually more favorable at years to decades. Grades 3 and grades 4 are usually high grade and aggressive, and the median survival is usually much lower. So back to our patient here, she had a grade 2 oligodendroglioma, which is usually a more favorable prognosis. She also luckily had 2 mutations that have more favorable survival prognosis. She was referred onwards for chemo and radiation. And it is now 2 years later, and she is doing well. Their most recent MRI only showed maybe small residual active tumor. Unfortunately, this is expected to recur over time. There is no complete cure for this. She will probably require additional treatment in the future. So in summary, this is our presentation on cranial nerve 6 palsies. Again, we picked this nerve because it is the most common and most frequently affected oculomotor nerve, and that you will come across in your practice. In adults over the age of 50, again, the cause is most likely microangiopathic, and imaging can be deferred. However, if the patient is young, less than 50, or in children with cranial nerve 6 palsies, the causes are usually much more ominous, and imaging is indicated. In young adults, usually think tumor or potentially multiple sclerosis. In young children, think tumor or other causes such as increased ICP or trauma. So in those patients, they should have imaging. And then what about for adults? So in adults greater than 50 years of age, if there is any other cranial nerve involvement or any neurological symptoms or deficits, if it is bilateral, that is not a microangiopathic cause. If there's any history of trauma or it's not resolving or improving after 3 to 6 months, imaging is strongly indicated. And when can you defer imaging? So it's a very small subset of criteria where imaging can be safely deferred. So they must be an isolated unilateral cranial nerve 6 palsy in a patient over the age of 50. And I would say that they should also have vascular risk factors, and it should also be less than 3 months in duration. You may want to consider also drawing a CBC ESR CRP to rule out the rare incidences where GCA causes a 6th nerve palsy. However, if you're following the patient and there's any progression and the patient develops any neurological symptoms or is not resolving, they should probably be referred or imaged. And I think next up is Dr. Ryan Mason, and I'm happy to take any questions at this time.
Perfect. So as Ryan's pulling up his slides, there was a question from Dr. Edsel Ng asking if anyone is using medial rectus Botox for the management of symptoms for an acute 6th nerve. And I know Dr. Kraft is here, so maybe he can take that one.
Can you hear me all right?
We can hear you well. Good to see you.
Yeah, it was, back 30 years ago, there was kind of a movement to, sort of inject any acute 6th nerve palsies or ones that we thought, might resolve or that might resolve over a period of time. And it's been shown in the long term, I'm talking about kind of microangiopathic or traumatic 6th nerve palsies, which were the most common, that long-term Botox didn't yield a better overall result, motor or sensory, than just observation. The only advantage it would have is that even if you expect it to resolve with time, is to create a divergence, and then as the muscles are recovering, you might get maybe a few weeks where the eyes might fuse and the patient might be diplopia free, and then you wouldn't have to use a prism. But in the long term, it doesn't seem to have any long-term benefits. So basically, except for treatment of a long-term esotropia where the patient is not recovering, and you want to have an alternative to surgery, then Botox is an option. But as far as management in the acute phase, it's no longer felt to be, a tool in our toolbox, so to speak, that we would use routinely.
Perfect. Thank you. And Ryan, floor is yours.
All right, great. I'd like to thank the department and Dr. Lamb for the opportunity to speak today. So I'll jump right into the fourth case. So here we have a 78-year-old woman that was sent to us from the optometrist with a new onset diplopia. Her past medical history, she had controlled asthma, hypertension, and depression, past ocular history of just having LPIs done in both eyes remotely, and recent routine blood work from the family doctor found no evidence of diabetes or thyroid dysfunction. On history, about 13 days prior to presentation, she had developed significant sinus infection with a lot of periorbital pain and pressure, and was started on oral antibiotics by the family doctor. About 3 days later, she developed a horizontal binocular diplopia that on history was not fatigable. On review of systems, there was no headache, scalp tenderness, or jaw claudication. At the initial presentation, she had preserved asymmetric visual acuities, normal intraocular pressure, and normal pupillary responses with no RAPD. There was no globe displacement and normal retropulsion. She had normal lid position and function, and anterior and posterior segments were unremarkable. There was no chemosis or signs of orbital congestion. Looking more systemically and peripherally, she had normal motor and sensory testing, screen of other cranial nerves, such as the facial nerve were normal, and she also had normal cerebellar testing on finger to nose testing and rapid alternating movements. As part of the initial workup, she had visual fields done that were normal. Her OCTs were normal as well. And looking at the ocular motility, she had a right abduction deficit and a right esotropia that was worse on right gaze. So that suggested maybe pathology with the right lateral rectus. She also had a right hypertropia that was worse on right gaze and left head tilt. And doing the 3-step tests, that seemed to isolate toward the right inferior rectus. And it's much more likely that she would have a right hypertropia rather than a left hypotropia. Most likely the pathology was on the same side. So that really suggests multiple oculomotor nerve palsies were taking place. When we look at the approach to incontinent strabismus, I'm glad Dr. Kraft is here, so I stole this directly from him. We can think of mechanical and innervational causes. So we can think of things like trauma, bone, maybe fractures, mass effect, issues with the muscle, or issues with connective tissue. You'll recall in our patient, it was acute onset diplopia. There were no falls, no globe displacement, and normal retropulsion. That more points towards away from a trauma or tumor. No history of prior orbital inflammation, so contractures less likely. There was no scleral show, lid lag, or lid retraction, and she had normal TSH testing, so less likely to be thyroid eye disease. And at least systemically, there was no markers of systemic inflammation on screening blood work with a normal platelet count, ESR, and CRP. We can also think of innervational causes. So like Dr. Lamb mentioned, that can be broken down from supranuclear, nuclear, internuclear, infranuclear, neuromuscular junction, and muscle. So going through all these is beyond the scope of this talk. But in our presentation, our patient had a right hypertropia and right esotropia. And so both on the right side, so a unilateral presentation. And it was also an isolated presentation, meaning the absence of any non-ocular CNS findings with normal motors and sensory testing. So that kind of helps isolate the pathology to an infranuclear cause. And in particular, if you have multiple oculomotor palsies going on, you can think of a lesion within the cavernous sinus, superior orbital fissure, or maybe the orbital apex itself. So let's look at the anatomy of these structures briefly. With the cavernous sinus, there's 2 cavernous sinuses. They're located just posterior to the globes and just lateral to the sella turcica and pituitary fossa. And in between, you have the sphenoid sinus. There's multiple connections between the cavernous sinuses, such as the circular venous plexus and the basilar plexus. So pathology on one side can spread to the other side. And like Alan and Dr. Lamb mentioned, The inferior and superior petrosal sinuses drain the cavernous sinus to the internal jugular vein. The inferior petrosal sinus runs through Dorello's canal with cranial nerve 6. So if you have an isolated cranial nerve 6 palsy, it's important to look for signs of raised intracranial pressure, looking for papilledema. And if we go a little bit more anterior now, if we look at the intracavernous courses of the cranial nerves, we have cranial nerve 3 and 4 running in the lateral wall of the cavernous sinuses, along with branches of the trigeminal nerve, V1 and V2. Cranial nerve 6 runs within the cavernous sinus in very close proximity to the internal carotid artery. And not shown here, but you also have sympathetics running through the cavernous sinus. So if you have pathology or compression of cranial nerves 3, 4, or 6, that would manifest as ophthalmoplegia. Cranial nerves V1 and V2 would manifest as facial hypoesthesia. Or if the sympathetics are affected, it would manifest as a Horner syndrome. If we go a bit more anterior and look at the superior orbital fissure, it's about 2 centimeters in length and made through an opening between the greater and lesser wings of the sphenoid bone. The optic canal is in close proximity, being just supratemporal, but it is 2 distinct structures. The annulus of Zinn overlies the superior orbital fissure, and it divides it into the superior, intraannular, and inferior portions. You can remember what's in the superior portion through LFTs. So the lacrimal and frontal nerve, the L and the F, those are branches of V1. The trochlear nerve is the T, and the S is the superior ophthalmic vein. In the intraannular portion, you have superior and inferior divisions of cranial nerve 3, cranial nerve 6, as well as the nasociliary nerve, which is another branch of V1. And the inferior portion, you have the inferior ophthalmic vein. Now, clinically, it's basically impossible to distinguish between pathology in the cavernous sinus and superior orbital fissure because these are 2 contiguous structures. And it's not uncommon if you have pathology at one location, it will spread to the other. Now, when we think of the orbital apex, the distinguishing feature here is that it now involves the optic nerve. So if you have decreased visual acuity, decreased color vision, maybe an RAPD, especially if there's signs of orbital congestion, such as proptosis, then that helps isolate towards the orbital apex. You'll recall in our patient, she had normal visual acuity and no RAPD. So that really points towards pathology in the cavernous sinus or superior orbital fissure. As part of the investigations for Miss CS, she had blood work looking at signs of inflammation and infection that came back normal. And because she had the recent sinusitis and potential sinus involvement, we started with a CT scan in this case. So we have the coronal cuts of the soft tissue window and the bone window. Here you can see that the sphenoid sinus is opacified. And you may be able to appreciate there's some small hyperdensities here that could suggest fungal elements within the sinus. If we look at the bone window, we have a pneumatized clinoid process, and there's some localized erosion of the bone. And looking at the axial, the level of the cavernous sinus appears relatively unremarkable, but at the superior orbital fissure, we do have some herniation of contents from the sphenoid sinus. And the radiology report kind of reiterates this with the possibility of fungal colonization and pathology within the right superior orbital fissure. An MRI was also done. So these are axial cuts T1 sequence. And we can see again opacification of the sphenoid sinus. And at the level of the cavernous sinuses, there's no abnormal enhancement here. Looking at the orbits in the coronal cut, the orbits appear relatively unremarkable. For instance, if you compare the right and left side, they appear very similar. And with a T2 flare sequence at the level of the orbital apex, there's no abnormal enhancement here. So again, the radiology report kind of reiterates multiple paranasal sinuses being involved, and with potential cavernous sinus or superior orbital fissure pathology. So when we looked at the patient at follow-up at week 2, she had been started on an intranasal corticosteroid, Omneris, for the sinusitis and remained on oral antibiotic. Her symptoms have been improving. There was less periorbital pain and less double vision. Her visual acuity and pupillary responses were still normal. And her abduction deficit in the right eye had slightly improved. And the right esotropia and right hypotropia had also improved. At week 4, the pain and diplopia had completely resolved, and her ocular motility was further improved, full ocular motility now, and her ocular alignment was also improved. So this is interesting. If she has a clear right-sided fungal involvement of the superior orbital fissure, you would think that she might not improve without systemic antifungals, and that topical steroid might even make the situation worse rather than better. Because of the sinus involvement, she was assessed by ENT, who had noted findings of a chronic right sinusitis with findings consistent with an allergic fungal sinusitis. And because of this, she underwent a decompressive endoscopic sinus surgery. So what is an allergic fungal sinusitis? Well, it's an IgE-mediated type 1 hypersensitivity reaction, and it's really a chronic inflammation as a result of mucosal exposure to fungal elements. So it's really an inflammatory response rather than a direct invasion of a fungus itself. It will manifest as a thick nasal congestion with colored nasal discharge that's termed eosinophilic mucin and facial pain. So you can have findings of bony erosion through the sphenoid sinus, as we had in this case as a result of an allergic fungal sinusitis, just because of the chronic inflammation. And that can erode into the cavernous sinus, superior orbital fissure, or the orbit. In about 10 to 18% of cases, there can be a compressive optic neuropathy, cranial neuropathies, proptosis, or orbital congestion. So there can be ophthalmic manifestations. And it's a really compressive mechanism that leads to the sequelae. There can be pretty serious consequences as a result of this, even cases of stroke and death if you have compression of the carotid artery within the cavernous sinus. There are some criteria that helps aid in the diagnosis. This is from a case series in the 1990s of 15 patients. So all of them had the major criteria and most of them had the minor criteria. So again, findings of a type 1 hypersensitivity reaction with nasal polyps. Those hyperdensities may be noted on CT scan. In some cases, you may have positive fungal stains or fungal cultures, findings of bone erosion on CT, and patients often have a history of asthma or atopy. This is just an example from some pathology slides and the pathology report from our patient as a result of the ENT sinus surgery. With an allergic fungal sinusitis, you do expect to have some chronic inflammatory changes and edema within the tissues, but that's in contrast to an invasive fungal sinusitis such as a mucor, where you expect a lot more tissue destruction and necrosis. With allergic, you may have some fungal elements or even no fungal elements at all, as was in our patient, in contrast to an invasive fungal sinusitis where you expect a lot of fungal elements. Just to compare different types of fungal sinusitis a bit further, with the allergic type, patients will often be immunocompetent and have a history of atopy. The role of the fungus is really that of an allergen leading to chronic inflammation. There's no direct tissue invasion, and you can have multiple sinuses affected in a more chronic nature. With an invasive fungal sinusitis, you would expect the patient to be immunocompromised, with direct tissue invasion and a much more acute course. With the allergic subtype, the goal really is to reduce any fungal load that's there and involve ENT for debridement and aeration of the sinuses. That allows for effective delivery of topical medications such as intranasal corticosteroids. In some cases, oral corticosteroids can also be used. And they often do quite well even without the use of antifungals. That's in contrast to the invasive fungal sinusitis. Because it's a much more aggressive infection, it often requires a likewise aggressive treatment with often deforming surgery to remove all of the infected and necrotic tissue. And systemic antifungals are very important. When we looked at our patient 3 months into follow-up, she is now post-endoscopic sinus surgery and is doing quite well on nasal corticosteroids with full ocular motility and excellent ocular alignment. So just as a quick review, today we talked about the different causes of cranial nerve 6 palsy in adults versus children, indications for imaging of cranial nerve 6 palsies, the approach to multiple oculomotor palsies, and localization of pathology in the cavernous sinus, superior orbital fissure, and orbital apex. Thanks.
Thanks, Ryan. A couple comments here. So I think Dr. Kraft wanted to make a comment first, so maybe we'll go to Dr. Kraft.
Well, I just want to call. Well, first of all, I just want to compliment all the speakers and organizers. This is one of the best neuro-ophthalmology rounds I've ever seen. It's great start and raises the bar very high for the rest of the year. Can we go back, Ryan, to your MRIs of the orbits in that patient?
Yeah, sure.
Right. There, yes, okay. I mean, your case sort of evolved into the ENT aspects, and you know, obviously went to the prime diagnosis. But for, I guess, even for our neuro-ophthalmology colleagues and our general ophthalmologists here, there is a very interesting and important imaging finding on this patient. If you notice, now I don't have control of the arrow, but in the middle photo there, yes, there. Do you notice the array of the ocular muscles, the rectus muscles, is very typical of what you see in patients in the older decades, and it is a cause of an abduction deficit, which is not a 6th nerve palsy and not a true, orbital inflammatory or other cause, and it's one that's become much more commonly recognized in the strabismus world, and probably is worth broadcasting into the neuro-ophthalmology world as well. If you notice that the inferior rectus muscles are displaced nasally, and the lateral rectus muscles are displaced inferiorly, and that there's a large space between the superior and lateral rectus muscles. And what happens here is that the band, there's the intramuscular kind of fascial band between the superior and lateral rectus muscles, which is quite strong in children. Over the years begins to erode, and you end up with what's called a dehiscence of the connection between the superior rectus and lateral rectus, and then the muscle cone kind of rotates, and the inferior rectus rotates a little bit medially, as you can see, and that can cause a situation where the lateral rectus no longer abducts directly along the horizontal plane, and in fact becomes a depressor, and the inferior rectus becomes a bit of an adductor. And these patients can present with abduction deficits and diplopia in the distance. So the clinical criteria is a distance esotropia with diplopia, but near ortho or close to straight with single vision. And so the differential of an abduction deficit with a distance ESO greater than near is a dehiscence or a sag. We call it the lateral rectus sag syndrome, which you can see here in these orbital views. So in the absence of any positive findings in the cavernous sinus or the sphenoid sinus that was evident here, if all those investigations are negative and all you have is this orbital finding, you can explain the abduction deficits, diplopia, and esotropia based on this abnormal anatomy, which is progressive and gradual over decades. And the treatment for this is to tighten the lateral and move it back up, or to actually put the lateral and superior together in the extreme cases that sometimes these show. So there's an extreme form in high myopia where you actually get the eye in depression and adduction. And those are kind of extreme cases, but milder cases like this, you have to get the lateral rectus back in the horizontal plane and get the array of the ocular muscles back normally. say that's in the differential of an abduction deficit. So this is not it would not be a sixth nerve palsy, so to speak. It would be more of an orbital dystopia, if you want to call it. That approach is very different and is a diagnosis of exclusion, of course, because you have to rule out all the other neuro-ophthalmologic things that everybody very well presented today. But I would just point that out, that this lady would have had another reason for an abduction deficit and diplopia had you not found these other findings.
Is that what they call like an involutional esotropia then? Like, is that what involution?
It's involutional in the sense of sort of an aging phenomenon where these tissues start to thin out. And so what you find at surgery is that the lateral and superior are kind of not in their normal array, but are actually displaced a little bit. And you can see that the muscle is kind of off its horizontal bearings, so to speak. And so you have to pull the lateral rectus up with either a myopexy or a resection and elevation of the muscle to get it back in the plane. And that also rotates the muscle cone enough that usually the esotropia is solved for distance. And contrary to what you would think intuitively, it doesn't cause an overcorrection at near because they're already able to synchronize and to fuse at near. So you can call it involutional, but it is one of several involutional eye muscle issues that develop in the 7th, 8th, 9th decades. So just to keep that in mind in the differential of an abduction deficit.
So that's a great comment. Thank you, Dr. Kraft. So I think, the mechanism here is felt. I see a question in the chat that Dr. Margolin, my fellowship preceptor, answered very well. Ahmed was wondering if the right hypertropia, what the cause of that was. So we think in this case that it was a compressive mechanism, so that the fungal elements eroded through the sphenoid sinus and caused compression of the lateral rectus or inferior rectus. Or, based on Dr. Kraft's point, maybe it's possible that this compression caused a bit of sagging or torsion of the orbit and caused the displacement of the muscles. Is that possible? Or yes.
Perfect. Thank you, Cindy. And thank you to everyone for their comments. We've had some great panel discussion today. And I'd like to echo what Dr. Kraft said. I think Cindy and Ryan and Ellen have done a wonderful job starting off our Grand Round series for the year and have set the bar very high. So thank you to all three of you for a wonderful start to the Grand Round series. I will remind everybody, and Dr. Farinas, thank you for your comments as well. Thank you for joining us this morning. I will remind everybody that there is an evaluation link. I posted it in the chat box. I'll bring it back up for everyone. Please do complete these evaluations. They help us, but they're also mandatory for CME credits. And next week, we have Dr. Stefan Angton presenting on an update on Decime stripping only for Fuchs endothelial dystrophy. So I look forward to joining you guys there. Enjoy the rest of your weekend.
Great rounds. Wonderful rounds, Cindy, Ryan, and Ellen. Thank you.
Thank you, everyone.
Thanks.
Thank you.
Bye.
Sorry, Dr. Kraft, did you have something to say? I think I saw you waving your hand.
Yeah, I did. Can you hear me?
Yes, yeah.
Yeah, just I hate to burst a bubble here, but when we were talking about the three-step test for ocular muscle isolation, the three-step test classically is really only valid for oblique muscle palsies, and it's even dubious whether it's valuable for an inferior oblique palsy. It's certainly helpful to diagnose a superior oblique palsy, but it's negative. The three-step test has a negative head tilt test in about 25% of superior oblique palsies. So don't rule it out just because the head tilt test is negative on the third step. Inferior oblique palsies, which are very rare, they do tend to step out, but not always. But the superior rectus and inferior rectus don't base the diagnosis on a 3-step test because they are not considered to be diagnostic for those two muscles. So it's very helpful on a fellowship exam, you know, to put a 3-step to one of the vertical rectus muscles. But in practical clinical terms, I think you have to look for alternative diagnostic criteria to diagnose the palsy of one of those two muscles. So
Yes.
superior oblique palsy, yes, very valuable. Inferior oblique palsy, probably, but not to base your diagnosis on a 3-step for the inferior or superior rectus.
No, for sure. It's not specifically localizing, but just sometimes helpful for my thought process as to what areas I should be looking for. But yes, even with superior oblique palsies, I know you can get ET or XT with that. So I know it doesn't always follow the 3-step test. Thank
Right.
you.
Yeah. And even for superior oblique palsy, it's only positive 25%, 75% of the time. So it can be a 4th nerve palsy with diagnosed micro or atrophy of the superior oblique, and yet the head tilt test is still negative. So again, it's helpful if it's there, but if it's not to go off to look for other things. A great round, fantastic rounds, by the way. You know, boy, oh boy, are you going to set the bar high for the rest of the year?
It was absolutely
Congratulations.
Thanks for your very valuable input. Really helpful. Thank you.
All right, guys, I'm going to close off. We have to get to resident teaching. So thank you, everyone. Nice to see you guys.
Great. Yeah, good to see you too.
Bye.
Bye-bye.